Hi, my name is Maria King. I'm the CNM site director in California. I was recently in labour and delivery working with one of our new interns. We have a new residency program now in its third year, and the resident was in her first week in labour and delivery. She'd observed a handful of deliveries and was working with me that day and was undertaking the birth of this baby. The patient was a young primate who was induced at 39 weeks gestation due, due to gestational diabetes, diet controlled, but we suspected that the baby was rather large and macrosomic. So that was the main reason to get her induced prior to 40 weeks. Her labour was essentially uncomplicated, but when she started pushing, she'd been pushing for some time. And obviously, when somebody's pushing a long time, we're always cautious of the possibility of a shoulder dystocia. And as her pushing progressed and the head started to advance, it was advancing much slower than I would have liked. So I was anticipating the shoulder dystocia. The staff in the room, the nursing staff, were alerted to the fact that this may occur, as was the resident, but she was very new, so kind of out of her realms of what was going on, really. In hindsight, that's what I concluded. During the delivery, once the head was delivered, I noticed that there was some turtling that was taking place. So I immediately alerted the nursing staff to lower the head of the bed and to place the patient in McRoberts position. Obviously, we explained these maneuvers to the patient and debriefed with her after the fact. The McRoberts didn't resolve the dystocia, so the nursing staff were asked to perform suprapubic pressure, which didn't resolve the dystocia. So I had to place my hand inside the patient's vagina, and I did a modified wood screw maneuver, which immediately resolved the impaction of the anterior shoulder, and the baby was then delivered without consequence and handed to the awaiting NICU team. The baby's APGAR scores were 2 and 9. Baby had no deficits, no problems moving either of its arms. Once the neonatal unit were happy with the baby, they brought the baby to the mother and we initiated skin to skin. The patient sustained a small first-degree laceration, which was repaired without complications, and the baby's cord gases, which were obtained at delivery, the pH was 7.34 and the base excess was minus 3.3, so everything was good. I'm approaching my fifth year of working with OBHG, and working with physicians who support CNMs in an acute care setting has been something that I've relished to do since I emigrated from the UK 20 years ago, where physicians and midwives work very closely together, and it's great to see the relationship that we have with the physicians. They entrust our skills and our knowledge base and the difference that we can make with labouring patients, because we deal with physiology far more than what the physicians do. So most of the time we work with spinning babies maneuvers to try and get, OP babies rotated and delivered, thereby decreasing the need for further interventions. but they also, the physicians, trust us with our judgment. If we call because we're concerned about a patient for whatever reason, they don't argue with us, they don't question us, they come up and they take over, or sometimes we're all there together working on whatever needs to be done. So it's a great relationship, and I wish every facility in the whole country had this setting. My dream for the future at our site is to see the residency program succeed, so that we can at some point also bring in student midwives, because the only way we can get a combination of physicians and midwives into hospitals is by having new midwives. And of course, who better to train them than the people that are working in that setting? And we'd like to pilot that if it's possible in our area in California.